Okay, so I'm just going to start talking about the congenital hand stuff. I know some of you guys have heard this before, so if you have questions, just stop me and ask me along the way. I tried to simplify this so that it's focused on what you've been asked before on the OITEs, and there's also some hand CAQ questions in here too. Those are a little bit more challenging, but basically this is a broad review of the stuff that they test, and then at the end there's a whole bunch of questions, but that obviously will be on another day. So key things to remember about the embryology of the upper limb. I know this is that vague topic that we all remember from medical school that we dread. So upper limb development happens in that 4th to 8th week of gestation. And it's really important to remember because that's the exact same time that you develop the other organ systems, including the heart, and also when the spinal cord closes. So that's why you very often will get associations between hand abnormalities and other organ system abnormalities. And the lower limb development actually lags behind the upper limb by about 48 hours, so that's why that difference usually exists. So the limb bud originates at Wolf's crest, which you can see is that gray area on the drawing of the embryo there. And the initiation of that outgrowth of the limb bud is determined by the homeobox genes. However, you need fibroblast growth factors in order for it to actually continue. So if you have an interruption of the fibroblast growth factors, then you're not going to have appropriate development of the limb bud and length of the upper extremity. When you look at the limb bud in detail, the very leading edge of cells there on that limb bud is called the apical ectodermal ridge. That's all ectoderm tissue, if you remember that from embryology. And that's what contains all the DNA to determine the formation of that limb. If you focus in on that area, you can see the apical ectodermal ridge is this very thin area on the very tip of the limb bud. This is supplied by a vessel directly underneath it. You need that. Otherwise, if that gets interrupted, then you'll have a problem with development of the limb. And then the progress zone is all that cellular tissue underneath it, which is actually made up of mesoderm. So if there's a loss of the blood supply, then you also lose the mesoderm tissue too. Now, another area that's very important in limb bud development is the area on the caudal side of the limb, which is stained here, and that's the zone of polarizing activity. And this actually determines that anterior-posterior orientation of the limb, which is what anatomists refer to, but we call it radial ulnar. So this is what it can be interrupted and cause problems with duplication or things like mirror hand, that type of thing. And this is just a schematic so that you can try to figure out how each of these is referred to. The proximal distal orientation that we were talking about before for the limb bud outgrowth is determined by that apical ectodermal ridge. The anterior posterior, or that's also called the radial ulnar orientation, is the zone of polarizing activity. And then there's also a dorsal ventral axis, which is determined by Wnt 7A. And they're starting to get more information on that, but they have not really tested you on that substantially. So once you have the outgrowth of the limb bud, then the limb goes through apoptosis so that it separates into fingers because of the death of cells between those fingers. That's the interdigital clefting that you can see in this picture here. This is actually an embryo going through apoptosis so that you can see the fingers develop. Kind of cool. Any questions about the embryology part? Okay. Moving on to the specific anomalies. They occur in approximately 1 out of every 600 live births, which is actually quite often. The old classification system was the one proposed by Swanson back in the early 70s and adopted by the IFSSH, broken down into these different categories. However, this really wasn't based on any type of genetic influence or even structural understanding of these malformations. So they just kind of lumped together what they thought went together. So it wasn't a very great system in terms of prognosis or treatment. In 2010, Oberg, Mansky, and Tonkin proposed this alternative system, and it's since been expanded a few times in publications. It's quite extensive. This is just the abbreviated version, but it is currently up for review to be the proposed replacement classification system instead of the Swanson classification system. And this is based on embryology and the development of the growth plate versus the rest of the limb. so that it's a little bit more specific to the mechanism of the actual malformation. So in general, when you guys see kids with hand deformities, very often you might be the first person to talk to the family about this. And I'm not sure how many of you have seen this already, but sometimes when you have a kid who comes in and they've been given this tentative diagnosis by their pediatrician that may or may not be correct. So primarily you want to provide information to the family and support in whatever way they need for that initial visit. You need to help set up the appropriate referrals. And this goes back to talking about all of those other organ systems that we talked about that can be involved with upper limb problems. So you want to make sure that you get them referred for ultrasound if they need it to look at their kidneys, or genetics to assess other abnormalities or cancer risk, any of that kind of stuff. And then you also, the goal obviously is to optimize their function. And that's not always surgery. Sometimes that's starting off with a therapy program for stretching and splinting, or even an assessment with play therapy to see what they can do or need some help with. And then lastly, obviously, surgical care, which is to improve both the function for the child as well as the appearance of the hand, because that can have a huge impact on their social development. So the first topic we'll hit on is syndactyly, and this is failure of the apoptosis that we showed earlier so that you don't get digital separation. And according to the test question, this is the most common congenital hand anomaly. The incidence is about 1 every 2,000 to 2,500 births. It can be autosomal dominant in some cases, although most of the time, obviously, it's an isolated problem. And it may or may not be associated with other anomalies. Just keep that in mind. So the classification system is based on the morphology. There are a number of different terms that we use to describe syndactylies. The first being incomplete, which basically means that the skin bridge does not go all the way out to the fingertip. Complete obviously does go all the way out to the fingertip. Simple means that it's just a soft tissue connection between the digits. Complex means that there is usually synonychia, meaning there's one nail with a little cleft in the middle, and those bones are actually fused. And if you think about that, that's because of that ectodermal tissue on the very tip of the limb bud. All of those structures arise from ectoderm. So those are going to be fused together out distally as well. And then complicated refers to the presence of other anomalies, like potentially Poland syndrome, like you would see in some of the Symbrachydactylys, or even more complicated syndromes than that. So when you're specifically looking at the fingertips, you can see this ectodermal tough tissue at the very tip of that cellular picture there. Sorry, the collaterals are a little rotated, but this is just an indication that that apoptosis did not occur and that ectoderm tissue is still fused. Here's another example of a complicated patient. So this is Apert syndrome. Remember, they have that cranial synostosis as well. So they can have very, very complicated syndactylies of the fingertips. We sometimes refer to some of these as a rosebud deformity, where all of the fingertips are fused together. And this is not constriction band. So this is very difficult to separate. So in terms of assessing kids with syndactyly and figuring out what type of treatment options you want to offer them, the first thing to look at is, as you can see in this picture, you want to address the tethered border digits early, because those are the shortest digits and they are going to restrict the growth of the central digits so that they get an angular deformity if you don't correct them early. So these are usually done by about 1 year of age. Obviously, it depends on whether they have any other medical issues that cause you to have to delay. But you usually do not want to operate on both sides of the digit in a single setting, because you will compromise the blood supply. And very often these blood vessels to these fingers can be extremely small, so you may have a great blood vessel on one side and a really tenuous one on the other. And so you really want to plan this out as a staged procedure and do the central digits later. Although you can go in and separate the very tip of the finger pulp on the initial surgery to try to make that a little bit easier and help with growth. So as I mentioned, you want the plan for the entire hand. Here you can see that the fingertips were previously separated in this picture, while the rest of the syndactyly is still present. It's really important to pay attention to detail on these so that your flaps are well perfused and have good full thickness fat tissue on them as well. Really need to work on recreating that commissure in the web space. The nails can be very problematic, and so it's important to make sure that you reconstruct the sides of the nail bed. General standard of care treatment is full thickness skin grafts in the web space between the digits, and this can come from a number of different sites. The old technique was to take it from the groin. That's very thin skin and can be quite hyperpigmented and grow hair once the child reaches puberty. So a lot of people have gotten away from using that unless they really have to. Now I think most people take it from the upper extremity, either up at the antecubital fossa or at the wrist. And then the most important thing is make sure you put them in a dressing that's going to protect them, because if they keep messing with this, or if it gets wet or anything like that, you're going to have horrible results from complications of either infection or graft loss. These are just some of the problems that can arise. Graft loss is a problem, obviously, because of the dressing or because of infection. Sometimes it's unavoidable, but it's generally a good idea to, if it's in the summertime, recommend that these kids stay out of the heat so they're not sweating excessively in their casts. Just really make sure they keep it dry and come in for a cast change if there's a problem. About 25% of all kids will end up with web creep, no matter what we do. It is more likely to occur if you operate on these web spaces at a younger age, and also if there's any problems with it getting wet or infected. Some kids have a higher chance of keloiding than others, either due to family history, or there are some kids who actually have these really fat fingers that are just a typical look that are more prone to keloid. And some of those we actually end up putting on methotrexate preoperatively to suppress the overgrowth of that tissue. And then obviously nail deformity is one of those problems that's sometimes unavoidable just because of the extent of the syndactyly. But certainly we try to reconstruct that as best we can to make it the most cosmetically appealing. Any questions on syndactyly? Okay. So moving on to polydactyly. According to the old classification system, this was lumped into a segmentation defect. We now know a lot more about this, and seems to be more related to that zone of polarizing activity and some gradient issues with sonic hedgehog. So this comes in a number of different varieties. There's the thumb side that's affected, which is referred to as either preaxial or radial polydactyly. And then there's the small finger side of the hand, which is postaxial or ulnar polydactyly. The thumb duplications or radial polydactylies are a very large heterogeneous group of abnormalities. The majority of these present as just that isolated thumb duplication without other organ system abnormalities. However, there are some that can be associated with other abnormalities, so just keep that in mind. And the classification system that we use for radial polydactyly is the Wassel Classification system. Here's a summary of the Wassel Classification system. You can see type 4 is the most common type, and that's basically determined by counting the number of bones present from distal to proximal, and the level of the duplication is the number or type of the classification. So, for example, if you're looking at these types of thumb duplications, on the far left, you can see that there is fusion between the distal phalanx so that it is one bone. So that's a type 1. The second one, you see 3 separate bones, right? So that's a type 3. The next one down, you have the typical type 4. And then the far right is a type 6. Make sense? Do you guys understand how to count that? Okay. This is the both clinical presentation and the x-ray for a type 4, the most common type. You can see that there's a lot of angular deformity in the thumbs because of the eccentricity of the tendons. If you think about these duplications, they have one common muscle belly proximally, and then their tendon comes down into the level of the bifurcation and then splits so that part of it goes into each digit. So the line of pull that's represented here is going to be on the center part of those digits. Make sense? So it's going to pull them with that angular deformity towards the midline. And so it's really important to recognize this so that when you reconstruct this, when you remove one of those digits, you bring that tendon that is on the one that you're removing back around to centralize that tendon pull so that you can eliminate some of that angular deformity. There's always going to be some of that present, but it's really important to pay attention to that. There also has been a modification to the Wassel Classification system that came out later, and that was to add the Wassel Type VII, which is a Triphalangeal thumb. This is a funky thumb. So when you see Triphalangeal thumbs, you have to think about potentially there being another associated condition. And these are just a list of some of the more common ones. But just keep that in mind, okay? If you see 7 in there instead of 6, that's a funky thumb. This is just an example of some of these triphalangeal thumbs. And they can actually present in 2 different planes. So sometimes they are in the plane of the fingers and are not in that opposed position, and then other times they are in the opposed position and look like they're placed appropriately. But these can be a little complicated to reconstruct. So in terms of treating this problem, as I'd started to say, you want to make sure that you reconstruct the best thumb possible from the structures that you have. So typically that means removing the smaller thumb, which in most cases is going to be the radial thumb. However, there are some times when the ulnar thumb is smaller and less functional, and you need to do it the opposite way. So the most important thing is to pay attention to those collateral ligaments. Especially at the MP joint, if you have the type 4, there is a connection from the radial thumb that you're going to remove that you need to release for that collateral ligament, and then reattach it back down to the phalanx that you are keeping so that it stabilizes that joint. Because if you just take off the extra thumb and don't recognize that that collateral ligament was destabilized, then you're going to have a very floppy thumb that's not going to be able to be stable for grasp. And as I mentioned, you also want to pay attention to those extensor and flexor tendons because of that eccentric line of pull. So you want to make sure that you detach them from the one you are removing and roll them back onto themselves to create a straighter line of pull to allow that to correct that Z deformity. Some of these kids, however, still need corrective osteotomies down the road if they're significantly angulated. Any questions about that? Okay, so moving on to the postaxial polydactylies. These are the ones that we see more commonly. There are 2 different types, type A and type B. The type A is very similar to the thumb polydactyly, where it's a well-formed digit that has a firm skeletal attachment and can very often have functioning tendons in it. That one can be associated with foot polydactyly as well. And then there's the type B, which is the one that we typically see, which is that little floating nubbin on the side of the small finger. This is approximately 10 times more common in the African American population. It is inherited in a autosomal dominant fashion and is rarely associated with other abnormalities. The Caucasian population has previously been documented as having more abnormalities if you see both like a hand and a foot polydactyly in that patient. However, I think the incidence is actually a lot lower than they initially suggested. So just keep that in mind, that if you see a Caucasian child with polydactyly, just look and make sure that there's nothing else that you're missing to make sure there's not another abnormality.
Is it like both types or 10 times more common in African Americans, or is it like...
No, just the type B. Yeah. So this is just a picture of type A versus type B. Type A has that, it looks like a full finger basically. Same with like that thumb duplication. Whereas the type B is that little tiny nubbin that usually has a very narrow stalk that flops around that doesn't have any skeletal attachment or any function. It may still have the little nail bed or actually a nail plate on it because of that ectoderm tissue. Most of the time it comes off a little bit more distal than this picture shows. It's usually off the base of the proximal phalanx of the small finger. So in terms of treatment, type A is reconstructed just like the thumb. You want to make sure that you preserve bone and nail from one digit and augment it with the soft tissue structures just like you do in a thumb polydactyly. The type B, you primarily try to treat before they're 1 year old. You can do it obviously later than that if you need to. Most of the time when they are very small and have that really narrow stalk, you can either have these tied off in the nursery like a lot of the doctors do when they're just born, or you can clip them in clinic like we've done here. That tends to give you a little flatter scar, more cosmetic appearance with no neuroma. If they're older than a year, you need to bring them to the operating room to take them off there. So there's a number of different treatment options that have been done for removal of the digit when they're quite young. Typically, these were done with sutures, as I mentioned previously, but if you look at the parents of these kids who have that run in their family, you can see that little lump on the side of their finger where it was tied off. It's not real good at keeping it flush with the skin, and sometimes you can get a little neuroma in there because there is an artery and a blood vessel that goes into that digit, and when it's tied off, sometimes that just walls itself off into a little neuroma scar tissue. The method that I typically use is to just use the surgical clips to occlude this all the way down against the skin so that you get a nice flush scar. And these can only be done on the ones with a very narrow stalk. Just give them a little bit of local at the base of the extra digit. Apply the vascular clips in opposite directions to occlude the blood flow. And then you tell the parents that these stay on and dry up over time for the next usually 1 to 2 weeks until they fall off on their own. They desiccate just like the umbilical cord. Most parents are okay with that because they're very used to the clip on the umbilical cord and watching it auto-amputate. Questions about that? Okay. So moving on to Symbrachydactyly. This is kind of a confusing category if you haven't seen it very often. This has had a number of different names in the past and is really, really commonly confused with constriction band syndrome. It is totally different. So Symbrachydactyly is probably due to a vascular insult that occurs to the subclavian artery system. And if you remember that picture that I showed you of the limb bud as it was forming with that blood vessel underneath the apical ectodermal ridge and that progress zone of mesoderm tissue. So if there's interruption of the development of the subclavian artery system during the formation of those, the heart arches and all of that, then it's going to decrease the amount of blood flow to that tissue, and that limb bud is not going to form normally. However, that apical ectodermal ridge is still present on that limb bud, so you are still going to get the terminal structures in the limb, even though it is shortened. Make sense? So you don't have the vascular supply to that mesoderm tissue in the progress zone, so that's the part that gets shortened. This is a sporadic condition. It is not inherited. It is always unilateral. And the reason that that is thought to occur is because if you think about the heart arches forming, if that happened bilaterally, it would be terminal. So the pregnancy would not survive. These kids present with nubbins. So these are the ones that it's that ectodermal tissue on the very tips of the fingers. So you sometimes will see those little floppy nubbins like you get with an ulnar polydactyly. And they will have a little indent for a nail bed, or they'll sometimes have a full nail on them because that's that ectodermal tissue that's still present. And there's usually a little bone in there too. It just may be cartilage when you first see them. There is no foot involvement with Symbrachydactyly, but what you can get associated with this condition is Poland's anomaly, where you can have varying degrees of the absence of the sternal head of the pec. You can have a chest wall deformity. It's all related to that vascular insult. And you want to make sure that you identify that, because if these kids don't have the appropriate rib cage underneath that region from hypoplasia, then they can't play contact sports. So it's really important to note that. Obviously, when they're a baby, it's not a big deal, but when they get older, it is. So you want to just examine them and pinch them underneath in their armpits to see if they have the pectoralis. You also tend to notice some asymmetry of their nipples as well on the chest. So it's usually pretty apparent. So there's 4 different types that are referred to in Symbrachydactyly. The most common is going to be your short finger type. That's the one on the upper right. If you put the hands side by side or have them put their hands together, you will notice the difference in length, but very often it's very subtle, and a lot of people on the street wouldn't necessarily notice it. The central deficiency type, or what's also referred to as an atypical cleft type, is the one on the left. There's the monodactylous thumb type, where you're missing the other digits except for the thumb, and then the paramelic type, where it is truncated further up the limb, but still has those nubbins. So these are just some pictures of the short finger type, and this has both usually some type of syndactyly, so that the web spaces are not as deep as you see on the other hand, and also brachydactyly, meaning that the bones are shorter in the fingers. This is also the type that is associated most commonly with Poland's anomaly. So if you see this child in the middle, you can see that asymmetry of the nipples and of the musculature on the chest. Now, obviously, in a baby, when they're pretty pudgy, it's sometimes difficult to actually pick up on that muscular difference, but you can usually see the nipple difference, and definitely just want to pinch them to see if you can feel that muscle tissue in there to see if there's a difference. These are just some pictures of the paramelic type, and these can be somewhere up in the forearm all the way down into the hand, but they usually have these little nubbins on the end, either with or without fingernails. Just some more pictures of the atypical cleft or central deficiency type, and then the monodactylous thumb type. So you usually don't have to do a lot with kids with Symbrachydactyly. Most of these are extremely functional and they have normal sensation, so they will end up using this a lot better than you would ever initially think. Sometimes it's helpful to remove those non-functional nubbins, but you have to do that early. These kids get very attached to these extra digits and paint the fingernails, and it becomes part of self after a certain number of years. So trying to take them off when they're older is a little difficult. The only issue I'd say is if you look at this picture here where a child's holding a block between those fingers, if there are nubbins in the central portion there of that hand, then they're going to get in the way when they try to grasp. And the other consideration is that sometimes you can get hair wrapped around them or other things so that it injures the tissue and causes decreased blood flow to it, and they can become infected or ischemic. So just warn parents about that.
So in situations where they don't get it taken care of early and the child does get attached to it, but the child doesn't want to have the procedure, but the parents do, would you still do it?
It's an interesting question. I think it depends on how old the child is. But yeah, when kids get to school age and can participate in discussions, I think you need to take that into consideration and let the family talk about it. That's not something I would jump to removing right away. Those kids with the short finger type that I showed you that have that partial syndactyly do sometimes require syndactyly reconstruction because since their fingers are already short, you can give them better spread of the digits if you widen those web spaces for them or deepen them. Some people have done distraction lengthening of the short fingers in the past. I would say approach that with some caution because the nerves and arteries don't really like to be stretched and they leave horrendous scars. Some people transfer toes. That's what is actually in this picture here. They always look like toes. They don't look like fingers, but they are very functional. Or you can do a full free toe transfer. Sorry, this picture is actually the free toe transfer. The phalangeal transfer is if you have a lot of skin in those nubbins and it doesn't have that super narrow base, some of those you can take toe phalanges in their periosteum and insert them into the fingers and they will grow, but you have to do that at less than 1 year of age because otherwise the body will reabsorb them. So it's not always a very reliable treatment option. Other questions about that? Okay, so moving on to one that's always confused with it. Constriction band syndrome is referred to with a lot of different names. I'm sure you've heard some of these before, the amniotic band syndrome, amniotic band sequence, Streeter's dysplasia. We don't know why this happens. This is something that people have done research on for a number of years in sheep embryo and a number of different animal models. What appears to happen is that there is either some insult that causes a mechanical strand to cut loose from the lining of the uterus and compress the structures. But we do know that this occurs after the hand has already formed. So this is not something that occurs during hand development. This is much later on in the pregnancy. And so those fingers have already separated and formed into a full hand prior to this insult occurring. And this can come in a lot of varieties of severity and can also include like cleft palate and some other constriction bands around the lower extremities too. It can cause autoamputation of some of these digits. But the key thing to remember is that because that hand already formed, you then had that mechanical effect which pushed those fingers together, causing them to fuse, but the web spaces are still present. So this picture here shows the probe going through from the volar side to the dorsal side of the hand. You can see that little dot is actually the end of the probe where that web space is still patent. So these are termed acrosyndactyly, meaning that the tips are fused. It's not a full syndactyly. So they have that little fenestration down at the base that's very typical of constriction band. You don't see that in any other condition. Questions about that? Okay, so let's see if I can get through radial dysplasia. So this obviously is a pretty big topic. Radial dysplasia or radial club hand can be bilateral in a very large portion of patients. This does include thumb hypoplasia within the spectrum because it's all of that radial side of the upper extremity. It has a very broad spectrum presentation and can be associated with other anomalies. Remember, this is also because of the timing of this occurring, so that there are other organ system abnormalities. And a lot of these affect the heart. So really need to pay attention to that too. The associated conditions that are common with radial dysplasia include Holt-Oram syndrome or Holt-Oram, depending on who you ask. This is a cardiac problem. It's referred to as hand-heart syndrome. So that they usually have a VSD or an ASD in addition to the hand abnormality. And that is inherited in an autosomal dominant fashion. Vater is the one that you guys know the best, or Bacterial, depending on what abbreviation you prefer to use. This is obviously the ones that include these various different problems as well. So you need to make sure that you check all of that and set them up with genetics if there's a question. There also is Fanconi's pancytopenia. So Fanconi's is something that is picked up on usually on the initial blood screen after birth, so that the CBC shows this pancytopenia throughout. And this isn't necessarily picked up on the next one. It may rebound a bit, but this is an autosomal recessive inheritance, and these kids go on to develop cancer. So it's very important to pick up on these kids. There's a very typical look that people see in Fanconi's kids. They're very petite and have this Pixius face, and so these blood tests are sent off quite commonly if they have a high index of suspicion. Another one is TAR syndrome, which is thrombocytopenia absent radius syndrome. This one is a temporary thrombocytopenia of the platelets, and that tends to improve as the child gets older and is not associated with that poor prognosis. This also is autosomal recessive inheritance. These kids have thumbs present, but they don't have radii. So it's kind of an interesting presentation. So obviously these all have classification systems. They're not going to ask you names, so I'm not going to confuse with all of them. But basically they vary in severity from just slight shortening of the radius to complete absence, from the type 1 to the type 4. And this classification system was actually modified afterwards as well to include a type 0, which means that most of the abnormalities are found in the carpus and the hand, and the radius is actually relatively normal length. The initial treatment for radial dysplasia is going to include stretching and splinting. Some people go on to include soft tissue distraction with like a distraction X-fix. Some people in the past have also done varying types of centralizations or radializations of the hand on the forearm. This has varied in success, and I would say there is a very high recurrence rate with a lot of those procedures. In the past, some of them have actually caused trouble with the growth plate of the distal ulna, which causes shortening of that too, so you have to be a little careful with the rebalancing. Some people do radial lengthenings, same problem that I mentioned with the fingers. The artery and nerves do not like to be stretched, and so sometimes that can be quite painful and also leads to very ugly scars. And then some people also do free tissue transfers by using some of the joints in the foot to bring them up to the wrist to support the radial carpus so that it's no longer angulated depending on the severity. As I mentioned, thumb hypoplasia is also part of the spectrum of radial dysplasia. This previously fell under that failure of formation and undergrowth. This is a lot more complicated than that, we know. And this also can be associated with other anomalies. So just keep that in mind, because the thumb hypoplasia sometimes looks pretty benign, but it is part of this radial dysplasia spectrum. So thumb hypoplasia also has a classification system, with type 1s being something that you probably would never even notice. They may just have some slight decreased size of the thumb and of the bone structures if you compare them on that x-ray where they're side by side. Type 2, you probably would notice they sometimes can have some instability of the ulnar collateral ligament at the MP joint and may have a small first web space and a little bit of hypoplasia of their thenar muscles. However, those are usually quite functional, and so if they don't have that instability, it may not need surgical treatment. Type 3 is the one you really need to pay attention to, and this is what they like to ask you. It's a small thumb. There is significant hypoplasia of the metacarpal, and you really need to look at the base of that thumb metacarpal down at the CMC joint to determine how you treat this. 3A is the one that has a squared off base to the thumb metacarpal at the CMC joint. So that usually represents a stable joint. So that is reconstructible into a functional thumb. The type 3B is the one that tapers at the base of the thumb metacarpal so that you have instability of that thumb CMC joint, and that is not going to be a functional thumb. So that is the one that falls into the pollicization category. So that's your line right there is between your 3A and your 3B. Type 4 is a little floating thumb, kind of like that nubbin. It's a pouce flottant. And then there's also type 5 where it's completely absent. So this is just a picture trying to show you the difference. This is a 3A thumb, and you can see how small this thumb is. On the x-ray, it's actually more impressive, I think, than clinically. But you can see there are no thenar muscles on that photo on the left. But the base of that thumb metacarpal is squared off. So that's going to represent a stable CMC joint. So you could potentially do tendon transfers and make this a functioning thumb. This, on the other hand, has that really narrow tapered metacarpal base, and you can see how short that is. This is not a functional thumb. This is one that you're not going to be able to add enough tendons or structures to cause it to function like a regular thumb. So in this case, you would want to pollicize the index finger. Make sense? And then here's the type 4 with the pouce flottant. I tell people don't get rid of this at birth. It's good skin if you should need graft at the time of surgery. And then there's an absent one, which is the type 5. So just summary of treatment for these. As I mentioned, you usually don't need to do a lot with a type 1 unless they have some functional deficits. And those usually are tendon transfers or web space deepening. Type 2, want to look at that ulnar collateral ligament a little bit more closely, make sure that that's not unstable. Type 3 is a little bit more significant. So these are the ones that are definitely going to probably need an opponentsplasty, definitely the first web deepening, those type of surgeries. And then from 3B through 5, you want to offer pollicization if it's a functional thumb. Or, if it's not a functional thumb and they have a good index finger. So key things to remember about pollicization. You need the index finger to be supple, so it needs to have full range of motion. If it's stiff, they're never going to use it like a thumb. There also are some kids that are so radially deviated at the wrist, and their ulnar fingers are actually better than the radial structures, and they use an ulnar grasp. If you pollicize that index finger, they're also not going to use it because their brain is using the ulnar side of the hand as the more functional grasp side. So those are ones where you wouldn't necessarily jump straight to a pollicization. Okay, so I think we probably are going to have to stop there. Any questions about everything that we covered today?
So when do you time the pollicization surgery for kids?
So I think that varies depending on your training and your level of comfort. Some of it is looking at the kid to see how big they are. Some of these kids are tiny, and those blood vessels are tiny. So where I trained, I was taught we don't do this before age 2. Other people will do this at a year or even 18 months of age. If there is a problem with the blood flow to that vessel, you need to be able to fix that vessel. So we're talking about a pretty tiny artery in some of these kids. So, and there is really no data that shows that delaying till after age 2 causes any problems with that brain-hand connection, which was, I think, a worry for a long period of time. I definitely think you need to do it before they hit school age because hand use patterns are pretty well established by then. But I think in that 2 to 3 years of age time frame, you're probably fine. And a lot of these kids, too, have other abnormalities. So if they have heart issues, you got to let those work themselves out and make sure that they're stable before you go on to do anything to create a thumb. So that also can be a reason to delay the surgery.